I'm going to talk about liver lesions. My email is also here. I've done several fellowships, so if you need any advice, if I can help you guys in any way, decide your career or help your career plans. If you want to complain about your attendings at any time and you don't want them to find out, let me know. Okay.
Complain about residents as well?
Okay. Let's start. Eyes do not see what the mind does not know.
Good boy.
How many agree with that? Goals of the lecture. Characterization of liver masses. We'll discuss the imaging protocols. Malignant versus benign and specific diagnosis. MRI protocol. Briefly, I'll discuss the T1 weighted. We do spoiled gradient echo images, out of phase and in phase images. Does anybody know why we would do that?
Fat dropout?
Yes, to determine fat, focal fat or fatty infiltration within the liver, or to determine liver lesions, distinguished liver lesions that contain fat. I'll talk about those. Then we do T2 weighted images, fast spin echo with fat sat, shorter. You can do short TE or long TE, and I'll briefly describe why. So, out of phase and in phase, as I said, fat and water recess at different precessional frequencies, and on a 1.5 Tesla magnet, they go out of phase every 2.2 milliseconds. So they are out of phase at 2.2 and then in phase at 4.4. As you can see, when they go out of phase and they are in opposed phase, they cancel each other's signal, and there is drop out of signal. As you can see, this is the exact same patient. Here you've got liver and you see vasculature going through it, and on the in phase you can't tell whether the lesion contains fat or not, but here you can see there is complete dropout. This liver has diffuse fatty infiltration. Also on opposed phase, wherever there is fat and water, tissue that has significant fat and significant water, you can see dropout of signal as indicated by this black line around the organs, for India ink as it is called. Stop and ask at any stage if you have any questions or any confusions. There is also an entity that causes drop of signal on in-phase imaging. Do we know what entities would cause that? On the longer echo?
Iron deposition.
Exactly, iron deposition. I can go into the details of this, but I choose not to. But what happens is, as you wait for the longer echo, the susceptibility effect from the iron or heavy metals causes local inhomogeneities within the magnetic field and loss of signal, and that is what causes a loss of signal on the longer echo. MRI liver sequences, we do spoiled gradient echo 3D images with fat sat. I'll describe, as I describe the images, I'll talk about that. Pre-gadolinium images, and then we do post-gadolinium images, which is arterial phase determined by the test bolus, portal venous phase, and delayed. Additional delayed imaging can be performed if you've administered Eovist or Vopta, which are for certain types of liver lesions. T1 weighted images, why do we do that? To determine fatty infiltration, focal fat or diffuse fat within lesions. As I said, certain lesions like adenoma, HCC, or rarely you can find a lipoma, which would show loss of signal. Melanin, especially with melanoma metastasis, would be high signal intensity on T1 weighted images. T2 weighted images help with lesion characterization, for example cysts, hemangiomas, FNH and HCC. Dynamic images determine the enhancement characteristics. We can give extracellular agents or hepatocellular agents. Multi-enhance is excreted, 5% of it, the administered dose is excreted in the biliary phase, and it takes 1.5 hours for delayed imaging. With Eovist, because it is excreted more, up to 50% of the administered doses through the biliary tract, so you can do earlier imaging up to 20 minutes. Dynamic MRI late biliary phase obviously help with enhancement characteristics of lesion. Focal hepatic lesion. The features that aid diagnosis are margin and definition of the lesion, signal intensity on T1 weighted or T2 weighted images, in and out of phase as I said for fat and iron, enhancement patterns, central scar in some lesions and some also have pseudocapsule, and we will discuss these lesions one by one. Clinical features, I will not go too much into detail because we never get those details as a radiologist. It just says lesion seen on outside imaging. They'll never tell us that the patient has cirrhosis, or the patient, it's a female that is taking, or it's a bodybuilder taking steroids or oral contraceptives in case of a female. Anyway, if there's a known primary, you would suspect metastatic disease. Age, elderly, obviously, it will be more likely to be malignant primary or metastatic. Sex, females with incidental more likely have benign lesions. Chronic liver disease or elevated alpha-fetoprotein, suspect HCC. And as I said, oral contraceptives, steroids, you suspect adenoma. There is some literature saying FNH can also happen in that, but I am not convinced. It's not convincing. There is still debate on that, but adenoma, there's no question and no debate about it. Steroids or oral contraceptives do induce them and do cause problems in these lesions. Enhancing lesions, benign, FNH, adenoma and hemangioma, malignant HCC, metastasis and cholangiocarcinoma. So here are 6 lesions. We'll dissect them one by one. But is there anybody who wants to take this lesion and give us a diagnosis? Not describe the lesion. What do you think it might be? Anybody else? Okay. So here is a lesion on arterial phase imaging that has a central stellate scar in it. If you take a pencil, do you think you can draw this lesion out completely? Do you think its margins are very well defined? Okay, it's lobulated, I agree, but if you take a pencil, could you go around the lobulations? Do you think this lesion is predominantly infiltrative versus predominantly lobulated and well defined? Exactly, well defined. So one of the characteristics, and there's a lot of detail, but life is black or white like day or night, and the shade of grey is only 5 minutes at sunset and at dawn and dusk. That is how nature is, and that is how God created the universe. And try and follow, how the universe is, black or white. Don't try to live in shades of grey, and people do, unfortunately. So either it is infiltrative or it is not. Infiltrative is a worrisome feature. Similarly, if a lesion washes out, enhances and washes out, wash out. Remember, wash out is worrisome. So the two things that I am going to continuously talk about is margin, whether it is well defined or ill defined, and the other thing is washout. And it's the most worrisome of those two that determines whether a lesion is going to be worrisome or not. So as you said, this is well circumscribed or relatively well circumscribed. It's definitely not infiltrated. On T2 weighted images, you can again see the central scar, which is high signal intensity. And when you do fat saturated T2 weighted images, because the signal intensity from the background is suppressed, background fat is suppressed, the lesion relatively stands out. The structures relatively stand out better. Or your focus on these structures gets better because the background clutter is not so much there. So again, arterial phase images, you can see the lesion enhances. On portal venous phase, the lesion actually blends in with liver parenchyma. It's difficult to pick out the lesion on the portal venous phase. On delayed, you see the lesion well circumscribed, but what do you see in the central scar? Opposed to these images, what is happening with the central scar here? It blends in, correct? Why do you think that happens? Because the scar enhances, correct? So, non-enhancing scar here, non-enhancing scar on portal venous phase, and on delayed, it enhances. And then we give EOVIST, and what do you think is happening here? Is the lesion taking up EOVIST or not? It is, exactly. So the lesion takes up EO list. So what do we think now the lesion is? Well circumscribed central scar that enhances on delayed imaging, and the lesion does not demonstrate washout. So is it worrisome or not worrisome? Not worrisome. Exactly. So I'm going to continuously talk about margin and washout, and other features may fall into place and may not fall into place. And remember, not every lesion has read the book. So you can follow the book, but you'll stumble because not every lesion. But there are certain key factors that will distinguish a human from an animal, or a benign lesion from a malignant or worrisome lesion. Okay, so additional features are central scar, which is high signal intensity on T2 weighted images, as we saw. The central scar is hypo-enhancing or non-enhancing in the early images, and on delayed images it enhances, as we saw, and the lesion takes up EO-wist. It is FNH. Agreed? Does anybody have any questions or concerns? Please feel free to ask. I tell my residents and wherever I lecture, remember, the only question, the only dumb question in life is a question that never got asked. There is no other dumb question. Should we proceed? Okay, so focal nodular hyperplasia, it is a conglomeration of benign hepatocytes with malformed vessels and bile ducts within it. And that is why, because it has bile ducts, it takes biliary agents. It takes up biliary agents. T1 weighted, as I said, can be iso-intense or hypo-intense. T2 weighted, it can be iso-intense or hyper-intense. But each book you consult, it will say iso, hypo, hypo. That will all confuse and clutter your brains. So for sake of academia, I'm displaying these here. You want to follow these, that's fine. You want to memorize those, that's fine. If they'll all only confuse you, remember margin and washout. Those are the two things, and everything else will fall into place. Arterial phase, as I said, homogeneous blush. Delayed phase becomes iso-intense, which means does not demonstrate washout, and it takes up EO-wist. If you want to confirm that it is definitely an adenoma, it is definitely an FNH and not an adenoma, or not some other scar-containing lesion, you can give EO-wist. Additional features are thin central scar, as I said, ductules and venules, seen in up to half of these lesions, plus radiating septate, and may even have an incomplete pseudocapsule. Should I go to the next lesion? Okay, good. Everybody with me? Good. Okay. Sorry. See, this is the trouble I had. But who wants to take a guess at this lesion? Worrisome, not worrisome?
No, it looks well defined.
Excellent. This man picked me up, so I'm indebted to him already. But his answer is right, so I have to effusively praise him. He's given me a reason. But exactly, you take a pencil, can you draw it out? Absolutely, yes you can. What is the other thing that we are going to look for to determine worrisome or not worrisome? Washout, correct? So let's proceed. On T1 weighted images, out of phase actually, what is happening is the lesion stands out and there is drop out of sediment in the background liver. What does that tell you? That the liver has fatty infiltration. So this was actually a female on oral contraceptive. So that makes you think, and I picked up the phone and I said, I know it's a female, but is the patient on oral contraceptive? And they said, yes. And I said, do you not think that information would have helped it if it was on the requisition? And the clinician said, my job is to give you studies, not to make your life easy. Boom. Anyway, that's all right. But on T2 weighted images, again you can see the lesion stands out and it's slightly, mildly hyper intense. On pre-contrast T1, now this is T1 not out of phase or opposed phase, and you can see it blends in with the lesion liver, whereas you can see here it stands out, correct? Because the background liver is fatty. Here it blends in, On arterial phase, you can see the lesion avidly enhances. On portal venous phase, the lesion is still hyper intense, but on delayed, there is no washout whatsoever, correct? It completely blends in. You can also see, is it projecting that? Yeah, it is actually. It is. Your screen is better than mine, I tell you. It's projecting better there. But you can see that there is a thin capsule around it. Can you see that thin, fine line around it? So, what are we thinking now? Exactly. Not rocket science. It is as simple as that. First thing was well circumscribed. The second is it does not wash out. Arterial phase, portal venous phase, delayed phase, and this is eovist. What is it doing on an eovist? It's not taking up you. Correct? As I said, in order to distinguish adenoma from an FNH, only 50% of FNH have scar. So that's not something you can rely on all the time. But not taking up eovist is definitely something you can rely on. The other thing is, why do we need to distinguish between FNH and adenoma? Why do you think we need to?
Because adenomas have a higher risk of rupture or bleeding.
Exactly, and growing up, and they need to be followed up. But I am very much impressed with your knowledge. Which year are you?
Fourth year.
Fourth year, okay. So I am going to request you to let them answer because you know it all. There's no question. If I was going to give two shields, one would be to you and one would be to my friend Patel. But okay, so I'm going to expect answers from others. I'm not going to put anybody on the spot. Okay, so hepatic adenoma, benign tumor in women on oral contraceptive pills or hepatocyte stimulating agents like steroids. T1 weighted, as I said, it is variable. Why is it variable? Because it can contain fat or it can hemorrhage. So it, while books say it can be iso versus hyper versus hypo versus this, it is variable. T2 weighted, again, it is variable because of those things. It can contain hemorrhage, but it can be hyper intense too. Again, those two things, the border and the washout. Arterial phase, it's hypervascular. Delayed phase, it can be iso or hypo, it says. Additional features are delayed enhancing pseudocapsule, can have intracellular lipid, and if it is hemorrhaged, it can be heterogeneous. But as you can see here, as I demonstrated, there is a thin pseudocapsule around it. Okay, let's go to adenoma versus FNH. FNH is morphologic and functional, diagnosis is helped by functional and morphologic imaging with BOPTA or eovist. Multiple studies were performed back in 2005, 2006, 2007, which convincingly showed that the differentiation or distinction between the two can be adequately made. Let's go to our next lesion. Do we think this is bad or good? Bad. Okay. You think you cannot draw it out? Okay. So what is the next feature you're going to look for? Washout. Exactly. Excellent. So here on T1 weighted images, you can see the lesion. T2 weighted images, again, you can see the lesion on T2 weighted single shot images. The lesion gets actually brighter, remains as bright as the bile in the gallbladder or fluid in the stomach. I'll talk about that later. On arterial phase images, you can see the lesion here. On portal venous phase images, you can sort of see the lesion here. And on delayed, you can again see the lesion enhancing. What do we think now? Is it good or bad? That's all right. There's nothing wrong with being wrong. Is there washout? Yes or no? No. Exactly. So I said, between those two features, whichever is most worrisome, is washout. Here, so the lesion enhances. Maybe you think it's not well circumscribed. To me, I thought it was. Maybe I was wrong, but it definitely does not demonstrate washout. It is still enhancing, correct? So it fulfills the criteria of a flash filling hemangioma. It enhances in the arterial phase and does not demonstrate washout. Distinctive features: high signal intensity on T2 weighted images, and enhancement follows blood pool. It follows the enhancement follows the blood pool. It does not wash out. This is a flash filling hemangioma. Everybody with me? Any disagreements? I'm going to give a shield for disagreement too. Okay, so hemangioma. There are three types. Type 1 demonstrates immediate complete filling, small hemangiomas less than 1.5 centimeter. Type 2 demonstrates peripheral nodular filling, which if you wait long enough will completely fill in. And type 3 demonstrates peripheral nodular incomplete filling, that is in the case of giant hemangiomas more than 5 centimeter. Okay, so let's look at this lesion. Can we draw this lesion out? Yes, well circumscribed lesion. Look at the characteristic cleft or notch, as it is called. So that is another characteristic of type 2 hemangioma, and on heavily T2 weighted images it follows that of fluid. It does not demonstrate dropout in signal, whereas there are certain lesions, and I'll describe them later, which as you increase the T2 weighting, as the images are more and more heavily T2 weighted, the lesion drops out in signal. So what is happening here? Yes, progressive filling in, and if you wait long enough, it will completely fill in. So this is a type 2 hemangioma. Let's talk about type 3 hemangioma. As I said, can you draw this lesion out? Can anybody spot any other lesion? Exactly, yes. So there's a lesion there and there's a lesion there. And on T1 weighted images, you can again see the two lesions. What is happening to the larger lesion? On arterial phase, you can see slight blush. It's progressively filling in, but does not completely fill in. Delayed Eovist, it's not taking Eovist because it is hypo-intense to the liver, correct? It's hypo-intense to the liver. Look at the second lesion. What is the second lesion doing? It is also progressively filling in. This is a type 3 hemangioma and this is a type 2 hemangioma. And look at the bile layering up with Eovist. Eovist is lighter, so Eovist forms a fluid level within the gallbladder with the bile. Everybody with me? Any questions? Excellent. Complete filling. You cannot rely on complete filling because incomplete rim of nodular enhancement that increases centrally over time. If you rely on complete filling, the sensitivity decreases and the specificity does not increase because you have limited or finite time per patient on the magnet. You cannot wait for 30 minutes or 40 minutes for a lesion to completely fill in. But what you can rely on is number one, the margin or borders of it, and number two, whether it washes out or not. Let's look at the next lesion. Okay. Good or bad? Can you draw it out? You can. Okay. What is the next thing you're going to look for? Exactly. What is happening here on in and out of phase images? Dropping out, exactly. What are the lesions that demonstrate fat? One was adenoma. What was the other one?
HCC.
Exactly. HCC or a lipoma. So let's look at this lesion now. On T2 weighted images, the lesion is sort of has some hyperintensity in it, but most of it is iso-intense, therefore it is heterogeneous, correct? It does not have a homogeneous signal. It definitely has fat, so you're thinking of either an adenoma or a lipoma or an HCC. What is this lesion doing between arterial and delayed? Predominantly, I know it's heterogeneous, but what is the predominant effect here?
Predominantly washing
Exactly. So what do we think this lesion is?
HCC.
Perfect. Perfect. You pick up the phone and you call the clinician and you tell them, is the alpha fetoprotein elevated? They say yes. You tell them, would it, no, did you not think it would have helped if you had given us this information? They'll say, my job is to do my job, not to make your life easy. Thank you for the information though, And don't even expect thanks. Sometimes they don't even thank you. But that's all right. Life does not consist of holding good cards, but to play a poor hand well. Correct? You know, you give 3 aces to a monkey and he'll win every time. All he has to do is put the cards down. So take pride, you know, in what you do, because you never see the patient, you never get the history, you get the most intricate, complicated, difficult cases. You put the pieces together, you give them a comprehensive diagnosis on which everything is based, and they never thank you. But your reward is not the word thank you. Your reward is, and the thing you take pride in is that you do something like nobody's business. Correct? You do it so well that nobody else can do it. Giving an aspirin or a hypertensive or a diabetes medicine, anybody can, even a pharmacist could do that. But what you do, nobody else can do. You know, I'm here to make you feel good about what you do. How many of you, how many of you think that it is possible to live an extraordinary life, an exceptional life? How many do you think that it is possible to do that? Excellent, almost all. How many of you do you think are doing that? Living an extraordinary life, living an exceptional life. Excellent.
Excellent. You raised your hand?
Let me tell you, by raising...
There's always exceptions.
I tell you, but by raising your hand, you told me that even if you're not living it today, you will definitely live it in future. It is all about attitude. And let me also tell you how you can live an exceptional and extraordinary life. Work harder on yourself than you do on your job. Work harder on yourself than you do on your job. Hard work on your job earns you a living. Hard work on yourself earns you a fortune. Does everybody agree with that? Any questions? Should we move to the next? Excellent. Okay. So additional features is lipid content, and you can have a capsule or pseudocapsule around it. Also elevated alpha-fetoprotein can help. But as a radiologist, you're going to rely on margin and washout. Remember that, you know. Otherwise, books and literature will always confuse you about T1 hypo-intense, T1 hyper-intense, T1 iso-intense, and everything on T2 is similar. Hypo, isos, and everybody will advocate their cause, you know. So hepatocellular cancer, most common malignant liver tumor, T1 weighted images, I've said variable, you know, because it can contain either fat or hemorrhage. And T2 again, variable iso or hyperintense. Arterial phase hypervascular, rarely hypo. Delayed hypointense because of washout. Additional features which may or may not be present is pseudocapsule scar and history of cirrhosis or Hep B, which you may or may not find out until you call the clinician. Regenerative and dysplastic nodules, I'm going to briefly describe them, and the reason is because, you know, there is a process of neoangiogenesis because of the tumor cells within the HCC or dysplastic or regenerative nodule. As it progresses, there are certain factors secreted by the lesion itself that causes neoangiogenesis within it, and it progresses from a regenerative nodule to a full-fledged HCC. Here is a patient, and you can see there are 1 million nodules. This patient is like somebody won the lotto, 100 million lesions, you know, instead of $100 million. And on T2 weighted images, you can sort of, you know, say it is all heterogeneous, and you can also see these high signal intensity strands. Everybody can see that? These subtle high signal intensity strands which correlate to these areas of low signal intensity linear bands separating these lesions. What do we think these are? In a cirrhotic liver with multiple, a bazillion nodules, regenerative nodules are these nodules, but what is separating or intervening between these lesions, these high signal intensity linear bands?
Blood vessels?
Fibrosis. Blood vessels, you would not see high signal intensity